Thank you, and welcome everybody to my presentation today. As a prelude to the presentation, I wonder how many of you recognize these two people up on the screen. People who are close to my age group may recognize the person on the left, and that is Detective Joe Friday from the old TV show Dragnet. And over on the right, Tony Shalhoub played the character Monk, another detective. And getting back to the topic today, people may be wondering, what the heck is somebody who's in rheumatology talking about the oral exams and the examination of the mouth? Well, to me, medicine or practicing medicine as a clinician is being a detective. The crime comes in with the chief complaint. Somebody has larcenously taken away my well-being. And it's up to us as the detective, as the physician, to find out specifically what was taken and why it was taken and what we can do to take the perpetrator away from what they've been doing to take away somebody's well-being. Now, Joe Friday on Dragnet was a to-the-point kind of room 9 ICU kind of guy. His mode of operandus as a detective was just the facts, ma'am, just the facts. He didn't want any extraneous information. He just wanted to get right down to what the facts were. On the other hand, Monk, as an obsessive compulsive person, seemed not to be paying attention to anything the victim or the witness / patient was saying, but was paying attention to the aromas in the room, what the furniture looked like, what the clothing was like, what music was playing. But in fact, he was paying attention to all the little nuances. Interestingly, both TV shows, on every episode, the Jack Friday, just the facts, ma'am, or the Monk, I don't know what's going on, but I'm paying attention to everything, always solve their crimes. And in medicine, we again have to solve crimes. Now, oral exams were things that I was unfortunately having to deal with as a medical student back in those days, and they've been done away with. Had to deal with for ped room boards, and they've been done away with. But I don't want us to do away with the oral exam of our patients. The mouth can be an important clue to what make people think that they've lost their well-being. Sometimes they have a complaint directly to their mouth, but most often, at least from us, they have other complaints of loss of well-being, and maybe, just maybe, there are clues in the examination of the mouth that can help us understand what's going on to cause their other complaints, or what may let us know something at the state of affairs of their other illnesses or complaints. So I have no conflicts for this presentation. I'm not going to be discussing any off-label treatments in this presentation. And as sort of already alluded to, I'm going to try and focus on recognizing the value of examining the mouth and appreciate the causes of abnormalities in the physical exam of structures in the mouth that might clue us into what other things are going on in the patient's well-being. The mouth and the clinical exam. Well, everybody knows an exam begins with inspection and auscultation and palpation and percussion. And examining the mouth, obviously looking at the mouth, at the outside and the inside of the mouth, is inspection. Auscultation, we don't put a stethoscope to the mouth, but we hear what the patient is saying, we hear what the parent is saying, and pay attention not just to the facts, but the nature of the voice of the patient or the cry of the patient. If we see something on inspection that is unexpected, we certainly should palpate and feel to see what it feels like. With regards to percussion in the mouth, the only thing I can say that I use percussion for is if somebody has complained of ear pain or throat pain, but their ear exam and throat pain is normal, even if their teeth look normal, because of shared nerve innervation of the mandibular molars. If you percuss on the molars, even if they look normal and they jerk away, they may have inapparent dental decay. So even percussion becomes important in the exam of the mouth. With regards to auscultation of the voice quality, if it's hoarse, it may simply be somebody's been screaming at a basketball game, or they may have an infectious laryngitis or postnasal drip allergic laryngitis. At the same time, if they also have joint complaints, it could be an arthritis of the cricothyroid joint, Or it could be subglottic stenosis that causes hoarseness that we see with ANCA-positive vasculitis like granulomatosis with polyangiitis. If they have joint complaints and also are hoarse, ceramidase deficiency of Farber disease has a liquid-like deposition in soft tissues in the joints and can be also in the larynx. And if they're terribly sick with fever and systemic disease and also have hoarseness, they may have the auto-inflammatory disorder of haploinsufficiency A20. The hyponasal voice certainly can come from a lot of features, but if it's palatal weakness, it might make us think about dermatomyositis or weakness associated with another autoimmune disease with acetylcholine receptor antibodies or muscle-specific tyrosine kinase antibody of myasthenia gravis. The weak voice may be a reflection of cardiorespiratory insufficiency, interstitial lung disease, chest wall restriction from weak muscles and dermatomyositis, or encapsulation of the chest with systemic sclerosis. So auscultation of the mouth becomes important. More often, we are dealing with inspection, looking at the lips, looking at the lining of the cheeks, the tongue, the palate, the gums, as well as examining the teeth. Certainly, starting off with a patient who comes in ill with red, cracked lips that look like that, whether we look at or the tongue or not, or see the acroerythroderma of those fingers, we think about Kawasaki disease. On the other hand, if we have patients who have complaints of stiffness in their limbs or other skin findings, and we see on the lip surface these hypopigmented areas with a different texture than the rest of the lip, it may be a clue that we're dealing with scleroderma, with these Morpheus lesions. And then there are those painful lesions, those canker sores, those oral stomatitis things, those fever blisters that we see so regularly. They're usually painful, but can be painless in some situations. Sometimes they're very apparent, sometimes they're less apparent, and we end up referring to them as being Apthous stomatitis. And Apthous stomatitis certainly, probably more commonly, comes from those braces that I just had put on, or I ate some hot pizza, or I bit my lip. Mechanical reasons, but certainly there are infectious reasons. Sometimes Apthous stomatitis can be associated with syndromic features that don't have a specific diagnostic test, a lab test, or pure pathologic diagnosis like Behçet's disease or Marshall syndrome that we know as PFAPA, or Magic syndrome with mouth and genital ulcerations with inflammatory cartilage disease or chondritis. Then there are the monogenic syndromes that are associated with auto-inflammatory diseases like haploinsufficiency A20 that refer to hyper-IgD or HIDS, previously known as Hibernian fever, associated with mevalonic kinase deficiency, or TNF receptor associated periodic syndromes, the CEBP associated autoinflammatory insufficient neutrophil function syndrome with oral ulcerations, and cyclic neutropenia. All of these are monogenic diseases that have lots of clues that we can think about, but then can be confirmed by doing genetic testing. Then there are those polygenic diseases where there may be autoantibodies present when active, but need a pathologic diagnosis from tissue biopsy to confirm a diagnosis like Crohn's disease or celiac disease. And there's patients who have nutritional problems that can cause on their own Apthous stomatitis, iron and zinc deficiencies, and various vitamin B deficiencies that may come from just insufficient diet or may come from malabsorptive syndromes. And then for us, at least in rheumatology and some other fields where methotrexate is used, you know, that medications can also be causing recurring sores in the mouth. Of the infectious causes, we typically end up blaming HSV for many of them, but we can see them with a number of other viruses. For old-timers like me who came along before we had much in the way of immunizations, or now younger folks who are seeing patients whose parents have been vaccine refusers, we may see patients with fever and rash and swollen lymph nodes. who in fact have these little white spots with red halo-like lesions around them called Koplik spots of measles. But nowadays, at least for the past year, we may be seeing patients who present with oral ulcerations because, in fact, COVID-19, which associates with the ACE2 receptors, the oral mucosa, just like the gut in kids and the kidney in kids and the lungs in older kids and adults, have a richness of ACE2 receptors, and that may be the first site of clinical infection with COVID-19. So we see people who have sores in their mouth, on their gums, in their cheeks, on their palate. And, you know, common things are common, but sometimes common things are not common, and it's worthwhile doing at least a cursory review of systems and getting some preliminary lab work, because sometimes these ulcerations, whether painful or painless, can be associated with systemic diseases like lupus. And we'll look at either the SLIP criteria on the left or the more updated ACR-ULR criteria. We can, if I get my pointer over here, we can, I'm having trouble with my pointer, but see on line 3 on the SLIP criteria, and over on the right side in this ULR criteria, that oral ulcerations are in fact presenting features that may be the source of finding lupus. Like this boy who came to our emergency room a number of years ago. I happened to be down there seeing another patient and heard the emergency medicine resident who was rotating through our ER talk about seeing a teenager who had the worst herpes simplex lesions he had ever seen. He'd been treated with acyclovir for well over 3 weeks at other emergency rooms and immediate care centers and was no better, was terribly dehydrated. And he was planning on admitting him, and he'd gotten the CBC. And I asked him about the CBC, and he said, well, his white count was kind of low and he's a little bit anemic. I said, well, on his way up, why don't you get a urinalysis? And he was admitted for his herpetic stomatitis and dehydration. And with the concern about this bad herpes, they consulted ID, and Dr. Bryant saw him that afternoon and called me and said, well, his herpes looks a whole lot like lupus because he's got proteinuria and casts in his urine in addition to his abnormal blood count. And he just doesn't look like he has herpes. And she was correct. He had lupus with lupus nephritis, as a matter of fact. So don't blame those bad persistent herpes on herpes. We can see all oral ulcerations as well with other diseases. It can be painful in the mouth. And sometimes if we look carefully, besides seeing oral ulcerations, we can see things over here in the mouth that look out of place. And if rather than looking, we palpate, these may not feel like typical gingival or buccal mucosa, may be sort of firm and rubbery and granulomatous, and actually be a finding that we see with Crohn's disease, remembering that the mouth is on the upper end of the GI system. We know to look for around the perianal lesion, but certainly some people will present with oral lesions for their Crohn's disease. When our patients have recurring episodes of fever as preschool age kids, that along with their fever have sores in their mouth or large lymph nodes and complain of sore throat that lasts a few days and then they're completely fine, and it happens again and happens again. It may go along with patients who were first described back in 1987 by Dr. Marshall with Sandy Lawton, Kathy Edwards in Journal of Pediatrics with a syndrome that we know as PFAPA, that most people around the world we still refer to as Marshall syndrome. And the classification got more specified by Dr. Marshall and his group to include that these had to be regular recurrent fevers with periodicity in a young person with those features of the stomatitis and lymphadenopathy and pharyngitis. But they wanted the exclusion of cyclic neutropenia in a child who is otherwise well and asymptomatic and growing well in between episodes. More recently, there's been a revised classification criteria that have been put forth in order for a comparative effectiveness trial of patients with PFAPA. And they wanted to be more specific that there had to be at least 5 of these episodes over a 6-month period with no more than 2 months between episodes, in addition to ruling out cyclic neutropenia, making sure there wasn't an underlying immunodeficiency or an infectious problem, but otherwise well child. So how do we exclude cyclic neutropenia? Ideally, we will have a patient who has a low neutrophil count during these episodes of fever with oral sores and pharyngitis, getting CBC several times a week for a month and a half, and making sure that although they have profound neutropenia during their episodes, their neutrophil counts otherwise are in a very healthy range of greater than 1,500. If we want to confirm this diagnosis genetically, the Elaine gene that modifies neutrophil elastase can be done if insurance companies are willing to pay for it. Because of this confluence of unidentifiable sources for kids with recurrent Apthous stomatitis and PFAP and Behçet's, a number of both bench researchers at the NIH, along with clinicians from Turkey and Western Europe and North America, pool their clinical data and lab data to see if there are any things that would tie these syndromic features together. And they did find some linkages in some immune markers, the cytokine IL-12 family, the transcription factor STAT4, the pro-inflammatory cytokine IL-10 regulators, and chemokine receptors C1 through C3 all have linkages across the board from patients who don't fit PFAPA but have recurrent Apthous stomatitis, patients who fit PFAPA, and patients who fit Behçet's disease. Again, if we look at the SNPs between PFAPA and Behçet's for regulation of interleukin-12 and STAT4 and IL-10, we see shared SNPs, again with chemokine receptor shared SNPs. And with HLA markers, although we expect the majority of patients with Behçet's to be B51 positive, those patients are not B51 positive or very often B1501 positive, as are patients with a lot of patients with Behçet's, as well as just recurring Apthous stomatitis, which made people think about linkages in the way that this transcription factor STAT4 actually interplays with IL-12, which we know is important with the PFAP and Behçet's. IL-23 we see with Behçet's, as well as things like psoriasis, but not PFAPA, and how that leads to increased inflammation acting through the NF-kappa B pathway. With regards to the chemokine receptor 1, Behçet's patients have increased activity of CRC1 on their monocytes that stimulates more MIP1 alpha, which is also also known as one of the S100 proteins that we associate with inflammation. Whereas when it's modified by IL-10 as an anti-inflammatory cytokine, we have minimized interference with inflammation. So we have this Behçet's spectrum disorder that all have linkages together, but seem to vary based on increased severity based on those HLA associations, in spite of the shared SNPs that we see. To decide if a patient does qualify as having Behçet's, they need to have 3 of these 6 features, though. Can't have just 1 episode of sores in mouth, but should be at least 3 attacks per year. There should be a history of genital ulcerations at least once. They have skin lesions like folliculitis, things that look like acne at a prepubertal stage, or erythema nodosum. Inflammatory eye disease is a feature that we see in Behçet's, as are the neurologic features, similar to the boy who we had here several years ago, who'd been treated multiple times for ADEM and relapsed each time as a 12 or 13-year-old. But going back through his history, he'd been having sores in his mouth since he was 6 years of age, and his white matter lesions were quite consistent with his diagnosis of Behçet's, as were his folliculitis-like lesions on his skin and his arthritis that he presented with when he came here from his other outlying hospital. These patients can also have recurring or one-time significant thromboses, either in arteries or veins, or they can have arterial aneurysms, can be devastating at presentation. Now, this girl started with just some sores on her tongue, but eventually had more profound lesions for Behçet's. And those sores in the mouth can progress to be leukoplakic or have ulcerations like this teenager on her labia majora, or these skin lesions in the perianal area with Behçet's disease. As we talked about before, there are monogenic illnesses that we see with oral ulcerations, the CBP epsilon mutation, the haplotype A20 disease, the hyper IgD mevalate kinase deficiency, as well as a polygenic disease like PFAPA, Behçet's, and Crohn's disease. NF-κB1 mutation, when it's homozygous, is associated with oral ulcerations, but a very profound immune deficiency that would fit into a CVID pattern. But more recently, people have pulled together patients with heterogeneous, just NF-κB1 mutations that were heterozygous rather than homozygous. And in fact, even this group of patients, we see 18% have sores in their mouth, and frequently have patients who have problems with the GI tract that look like IBD and splenomegaly, like a patient who we had in the hospital this November who has a new SNP in his NF-κB1 gene that is a heterozygous mutation. I have talked a lot about this haploinsufficiency A20 with the TNF-AP3 mutation. This was recently diagnosed and reported by Dan Kastner at NIH that he found in a family with this gene mutation that produces abnormal A20 protein, which is a regulator NF-κB enhancer for B lymphocytes. What makes this clinically distinct from Behçet's is, in addition to mouth ulcers, in addition to uveitis, skin lesions, genital lesions, they do have pathogy, as we see, particularly in Europeans with Behçet's, but they have laryngitis and kidney involvement, which we don't expect to see with Behçet's. And again, this is something that we can confirm with genetic testing. Talked again previously about hyper IgD. Unlike PFAPA and cyclic neutropenia, these patients don't have any periodicity to their episodes of fever. They last about the same length of time as PFAPA, and they may have adenopathy, may have Apthous sores, but they are typically fever with arthralgias at times, abdominal pain at times, rarely, but sometimes have rashes. And the clue to this periodic fever is the fact that there's not great periodicity to it, the length of the episodes, and the variability of symptoms with it, without an identifiable infectious problem. Before doing the genetic testing, if we do a first morning urine specimen during an attack, looking for increase in urine mevalonate or mevalonic acid, that should make us suspect and actually confirm the fact that what they have is hyper IgD syndrome. This, again, recently diagnosed canonic CBP epsilon mutation is associated with this neutrophilic specific granulite deficiency that also is associated with poor neutrophil function, as well as upregulating the NLRP3 inflammasome, causing a very severe inflammatory disease that can also have oral ulcerations along with it. Moving away from the lining of the cheeks and the lips to the tongue. When we see patients with geographic tongue, we are probably 95% of the time assuming that it's just familial and means nothing. But if they have joint complaints, we know that some patients who have joint complaints in geographic tongue may have formed thrust psoriasis and need to just look at the mouth and examine the joints, but look at their fingernails, scalp, their umbilical area, and the gluteal regions, the sort of classic places for psoriasis in children as opposed to the extensor surfaces that we see with psoriasis in adults. We also see geographic tongue in patients who have celiac disease that are still haven't been diagnosed and on gluten-free diets with active celiac disease. Besides sores in their mouth, they may have geographic tongue and also have joint complaints, as well as patients who have reactive arthritis may have geographic tongue in conjunction with their joint symptoms. When we see geographic tongue, but also see lobulation of the tongue, whether they have oral ulcerations or not, we should ask about presence of problems with dry mouth or dry eyes, as we may be dealing with deformed thrust of a patient with Sjogren's syndrome, which in kids requires at least 4 of these 12 features to be lumped into a study for Sjogren's syndrome. Certainly those patients who've had repeated episodes of mumps-like illness with parotid swelling, whether painful or not, recurring episodes of conjunctival inflammation or vaginitis, aches and pains in their joints or unexplained fevers, episodes of hypokalemic paralysis, renal tubular acidosis, hyperamylasemia, elevated SED rates or low white counts, serum protein electrophoresis that shows polyclonal hypergammaglobulinemia, dry eye as measured by a Schirmer test or lissamine staining of the eye, ultrasound of the parotid gland or abnormal scalography, and or the presence of anti-Rho or anti-LA antibodies, positive rheumatoid factors, or very high titer ANAs can give us the diagnosis of Sjogren's. If we don't have 4 of those 11 features, having a biopsy done of the interior surface of the lip where there are minor salivary glands looking for lymphocytic infiltrate may be the 4th feature to wrap up a diagnosis of Sjogren's. Moving on to the palate, we've seen a lot of palatal lesions. Just the anatomy of the palate may be important. When it's a high arched palate, might be thinking of somebody who is not yet grown enough to be recognizable as a classic Marfan's, and the subtypes of Ehlers-Danlos syndrome. But again, sores in the mouth with the vasculitic lesions of palate or with chronic palatal inflammation, leukoplakia, or dermatomyositis, we may see these ovoid patches in addition to a weak palate. When we ask them to say ah, whether they have a hyponasal voice or not, the examination of the palate becomes significant. Moving to the gums, we can see gingivitis or gingival changes, most commonly with poor oral hygiene, with tartar formation and mechanical irritation of the gums. But patients have scurvy or pellagra or vitamin B12 deficiency, patients with granulomatosis with polyangiitis, Crohn's disease, malignancies like leukemia and lymphoma may all have inflammation of their gums. Patients who are on medications may have gum changes as well. Plaquenil, especially if their levels are too high for too long, besides retinopathy, may have a greenish blue discoloration to their gums. Patients on long-term treatment with minocycline for their acne may have a brownish discoloration to their gums. And those patients who need to be on long-term cyclosporin or Dilantin can have hypertrophy of their gums, although we can also see gingival hypertrophy with puberty as well as in pregnancy. These are the gums of a patient with GPA, otherwise known as Wegener's granulomatosis. that ANCA-positive vasculitis. Getting towards the end of looking at the mouth is paying attention to the teeth. We can see discoloration of teeth that may be clued in by medications that they're on, doxycycline, Plaquenil again. Patients are on long-term treatment with ACE inhibitors, calcium channel blockers, or amiodarone can also have pigment changes to their teeth, as well as patients who have abnormalities in the appearance of their teeth from dental caries or structure of their teeth. Patients with Sjogren's syndrome and dry mouth are more prone to getting recurring caries or numerous caries. Last year, we had a 17-year-old who was admitted with abdominal pain and fever without a source, who had some oral ulcerations. And going through her history, she and her mom had major conflict over the fact that she had so many cavities in her mouth, and her mom was on her case since she was 11 years of age that she didn't floss regularly or brush her teeth enough. And the girl swore that she did. And in fact, she was anti-Ro positive and had dry eyes as well when she was sent to ophthalmology and the Schirmer test was done. We can also see increase in dental caries with patients who have inability to have good oral hygiene. If because of their scleroderma they can't open their mouth wide enough to get to their molars, or if they have bad polyarticular disease where the TMJs have impaired their intraoral aperture, they can't get back to their molars and take care of them. With celiac disease, there can be delayed dental eruption. They can have discoloration of their teeth, or they can have enamel defects that cause structural defects, in addition to having the sores in the mouth that they may also have. The enamel defects can be apparent with discoloration as well as these linear structural defects. And we know that patients with celiac disease, it is not appropriately true with a gluten-free diet, have increase in their interferon gamma and can have delayed dental eruption as well as these enamel defects because interferon gamma induces STAT1, that transcriptase protein that gives a gain of function and impairs amelogenesis that can cause tooth disruption. I'm rushing through what we've talked about and have gotten to the end of my discussion, but again, I think if we take that monk approach to paying attention to things that may not seem appropriate when people are complaining about totally non-oral complaints, as well as patients who take us to their mouth as their chief complaint, we can learn a lot by paying attention to what comes out of the mouths of babes. And with that, we're at the other end, really the other end. And I hope, although brief, the morning was not too rough and we can entertain questions or discussions. Thanks.